1, 2, 1, 2. Yes. Yeah. Check.
Right.
Who's up first? Who do I need to put microphone on?
David. I'm not up until much later, but you can put mine on too, and then just not.
Are you the second?
I'm the second speaker. There's only two of us.
We'll just leave it.
Okay. Okay. We may be at the front, which is the thing. So if you guys have control of it, right?
Yeah.
Yeah. Yeah. Just put it on, and so that I'm fine, and then mute it, and then. Yeah, thank you. All right, so that. This is my last talk.
That's a question for us? We'll turn it on for you. So once you get to your video slide, you just get there and
You can put it on. Yeah.
you don't have to touch it.
Yeah. Oh, do you have
any questions?
I'm walking into this.
So they will have like a polling thing
I don't know how to
use it. It's like it's internet based. So speaker timer. It's all ready to go. We have a whole new slide. Quick. It's this slide actually.
So much.
It should have all the presentations at this point.
So it's just this button, right?
That's it. Yeah.
And are you comfortable?
No, I'm sorry for making you guys
We're already recording. We're starting at the time. And speaker timer. I don't know colors for this. We weren't given any use. Change seats. I'll let it for you when I get back.
So they will
get the other one.
I'll have to ask him because he was here just
Yeah.
I mean, there's 80 slides in this. Is this just one presentation?
I think it very well may be. Yeah.
Number two. Want to mic me with number two? There's only two speakers, right? It's just me and David.
I did the last two slides.
So I'll just put that in your shirt.
On my shirt.
Right about there. And you want to just put this in your inside pocket?
Yep.
Do you have an inside pocket in your jacket?
Yep.
You're not using it?
Yep. I'm not using it. It's not that one.
You can put that in there.
Hey, babe. Thank you. Babe, we made it. Do you have any pictures of us here? Can you take a picture of me and my wife? This is Genevieve. Genevieve is from Valiant. Are you or OCI?
Project manager.
You're project manager at OCI, and OCI is putting to.
The communication agency program?
Oh, the communication group.
I'll take more than one. Do you want the background?
Yeah, do you want the background? Let's do all the background.
this program is actually quite meticulous and involved a number of individuals, including, in addition to myself, Dr. Gita Achuathan from Regina, Dr. Sean Morton from Toronto, and Dr. Gabriel from Montreal. Now, in terms of housekeeping details, please turn your phones to silence. This program is accredited by both the SCOPE as well as the College of Family Physicians of Canada and the Alberta chapter for up to 1 DINCO credit. And in terms of disclosures, the most important of which is I'm an obesity and diabetes advocate. And I'd like to collect money from whoever that would promote a world with fewer people affected by overweight and obesity and diabetes. These are the disclosures from my colleagues, Dr. Wharton, as well as from Dr. Daniel. And in terms of the disclosure of commercial support, this program has received financial support from Valiant in the form of an educational grant, and it also has an in-kind support from Valiant in the form of logistical support. In terms of the potential conflicts of interest, both Dr. Sean Wharton, Dr. Daniel, and myself have received honoraria from Valiant and from some of these other companies that are involved in the manufacture of anti-obesity agents. In terms of effort to mitigate the potential bias, the information that we present is evidence-based. The recommendations made are evidence or guidelines-based rather than personal recommendations of the presenter. And the program content has been developed and vetted through by a scientific committee. And the learning objectives of this luncheon symposium is first to determine the motivation and readiness for change in a person with overweight or obesity. And of course, when we're dealing with individuals with overweight, we're talking about individuals with comorbidity who also have overweight. To engage patients by asking appropriate questions to identify the personal barriers to change, to counsel them on the role of biological and genetic factors that contribute to obesity and weight regain. And importantly, to discuss anti-obesity medications and to help our patients to choose the right agent as an adjunct to the overall weight management plan. So the agenda is actually listed in the handout, and what we like to do is to start off by identifying the proper individuals, and I'll show you a few video clips. It's going to be very interactive, so we're going to start by asking you to text to a phone number, and so let's give that a try. But before that, please don't forget to complete the evaluation forms to help us to improve the future programs and importantly the content as well. So let's start off by asking you to use your mobile phone and text obesity 2017 one word to the number 37607. And you should get a response back from the number. Yeah, 37607. So everybody got on? And hopefully you'll get a response from the... Okay. So now let's do a polling question. What is your favorite winter sport? Is the answer A, skiing, B, skating, C, curling, D, hockey, or E, snowboarding?
I answered. I answered.
Are you able to text to so oops, let me go back.
Someone says you need to log in though.
Yeah, we did. We logged into poll not active, log in to
The
activate.
poll
Oh,
is
it's not active.
Log in to activate. It's a minor technical glitch.
If polling doesn't work, we don't do it.
Okay, so can somebody help?
Is the crew back there?
Okay, so are you folks able to text to 37607? And do you get a response back?
Yes.
Okay. Well, I'm surprised I won't get an answer here. So let's do it over again. Skiing A, skating B, curling C, hockey D, snowboarding E. Could you retext it and see what happens?
Yeah. We may need
No?
to skip polling questions and just go
Yeah,
with,
we may have to skip the
because there's
questions.
videos and stuff.
All right, well, let me start. The first portion of this presentation is assessing the right timing. That refers to mutual engagement in obesity management, to have a dialogue between the patient and the primary care physician. As you're well aware, Canada is no exception to other developed countries where we see a dramatic increase in obesity rates as shown on this slide. The bad news is that 1 in 4 Canadians is obese, 2 of 3 men are overweight, and 1 in 4 children is overweight. But the good news is that the curve is actually flattening, at least based on the OECD figures. But nonetheless, as you're well aware, obesity greatly predisposes individuals to metabolic comorbidities and many chronic diseases such as type 2 diabetes, hypertension, dyslipidemia, heart attack and stroke, and so on, just to name a few. But in fact, non-alcoholic fatty liver disease and obstructive sleep apnea syndrome are 2 of the more common conditions associated with obesity. Now let's see if the poll is working. It doesn't, okay. Let's try it again. So do you think patient counseling can have a significant impact on weight loss behavior? Yes or no? So I guess it's 1 or 2.
A or B.
A or B?
Yeah, it's usually. No.
Unfortunately,
it's not gonna
it
work.
doesn't seem to be active. Maybe we can see a show of hands in the interest of
Yeah. Old-fashioned.
We'll have an idea. So, how many of you would say agree with this statement that patient counseling has a significant impact on weight loss behaviors? Yays? Nays? Quite a few abstainers.
Yeah.
Okay. All right. Well, patient counseling certainly can have a significant impact on health behavior changes. And in particular, those individuals who report receiving counseling about weight loss are twice more likely to say they're currently trying to lose weight. So physician engagement and healthcare practitioner engagement is absolutely critical. So let's start with a case, Alain. He's a 47-year-old accountant with a BMI in the overweight category of 29 kilograms per square meter. His blood pressure has been on the high side, 150, and his LDL or bad cholesterol is 2.5, and the Framingham risk score is 20, putting him in a high risk for cardiovascular disease category. He's a smoker. He takes Ramipril 10 milligrams daily for blood pressure control, as well as atorvastatin 40 milligrams, which is a statin to lower his cholesterol. He started to exercise last year, and it actually has been quite successful. He has lost about 6 pounds. He was referred to a registered professional dietitian, but had difficulty changing his eating and activity habits because he feels his job is very stressful, and it's really a very typical pressure cooker lifestyle that he's living. So, now, let's see if it works. Okay, so which of the following are signs that Alain is not ready to change? A, he avoids the issue of his weight and makes excuses for it. B, tells you that he's too busy to make changes. And C, jokes about his weight gain. Or D, A plus B. Okay, so at least it's working. You can see the dynamic changes. Okay. So instead of telling you right or wrong, I'm going to show you a video of a man meeting with Dr. Daniel Gagnon. So please roll the video.
Glad to see you. How's the family?
Very good, thank you. Very busy with activities and all the other sports. Very good, thank you.
Happy to hear that. Last time we met, you were talking about... Okay, why don't we jump on the scale first?
I don't want to know the number.
Why not?
I've gained a few pounds since our last visit, but things have been so crazy at work and with all the kids' activities, I haven't had time to exercise.
It's a common complaint of patients, but what do you think about your weight over the last years?
Overall, it's been pretty good, but like I said, I'm in a rough patch. It's no big deal.
Okay, fair enough. It's not always easy.
All right, so there are potential number of talking points with Alain that we can talk about. It can be tricky to start a conversation on weight. An easier way to approach this would be to simply ask Alan to go on the scale. Patients often make excuses and say they don't want to see the numbers. It's also important not to tell them that he has gained weight, but he or she has to acknowledge that they have. In other words, they have to take ownership. So ask the questions such as, what do you think about your weight over the last several years? And it's important to determine if Alain is ready to do something about his weight. So the next question is, at the end of the appointment, what can you do to help him for his next visit and to motivate him towards the readiness to change? So the answer is A, remind him about the impact his weight has on his overall health. Suggest a separate appointment to discuss the situation in detail. Or encourage Alain to set goals, or all of the above. Okay, so D seems to be the most popular answer. All right, so let's see what Dr. Gagnon has to say in his conversation with Alain. Oops, sorry. Let me just go back. Can we please roll the video?
Okay, fair enough. It's not always easy to stick to our healthy choice, but keep in mind that weight has an impact on our health. Increasing our weight means increasing the risk of certain diseases that we all want to avoid. Hypertension, cholesterol, heart disease, diabetes. But the good news is that if we lose weight, we reduce our risk of becoming hypertensive, suffering from heart disease and diabetes. If we want, I don't want to overwhelm you with details for now, but if you agree, we can book an appointment and elaborate a specific plan together to help you to lose weight over a long time. Okay, here is your prescription.
Thank you.
Till next month, I would like you to think about your weight and setting goals that you would like to get in the next 6 or 12 months.
Sounds good.
Well, again, there are a number of talking points that we can now have a conversation with our patient. But if your patient is not ready, don't give up the conversation. Just take note of the patient's barriers and prepare him for the next visit. Weight loss, as you're well aware, is not just for cosmetic reasons, but here we're talking about improving health, reducing illness, preventing pain, and to improve the quality of life issues in all people that we interact with. State the facts. Tell the patient that his or her weight has as big an impact on their overall health and life expectancy as smoking, drinking, or diabetes, etc. It's important not to build a negative attitude towards the problem of overweight. As primary care practitioners, we need to engage the patient and determine what's stopping the patient from being ready by asking the questions. Has the patient tried different types of diet that have not worked? In other words, start a dialogue, engaging the person to become more involved and perhaps to think a little bit more about his or her weight and what are some of the efforts that he or she has tried. Now, when the patient is ready, there are a few things that we need to perhaps pay attention to and not to do because we want to be non-judgmental in our approach. So don't rush the conversation and overload the patient with too much information in the first visit. The doctor talk that all of us are very familiar with, we need to ensure that our tone is not perceived as paternalistic or maternalistic or condescending, but more important, as a coach, as a partner in the journey of weight management. Take ownership of the patient and his or her plan. Don't just send them to other healthcare professionals. In other words, just don't serve as a referral center. You play a huge role in the success of your patient's journey and program. And make sure the next follow-up appointment isn't too far away. In other words, making sure that you do have ongoing dialogue with the patients and to keep open slots in your schedule to accommodate your patients. And this is often referred to as open access scheduling. A few more talking points. Here's what you might want to consider doing when the patient is ready. Provide only the information needed for the first step during the first visit, and perhaps delay all the other information to the next visit so that you don't overload and overwhelm your patient. Because most of the time, patients hear what they want to hear and not necessarily everything that you have to say at that particular visit. And make sure that you engage the patient by having the patient talk and help him or her to create their own plans. In other words, short-term, intermediate, and long-term goals towards weight management. And acknowledge and praise the patient and commend the patient for their accomplishments and so on. And listen to the patient during the first visit and make sure that the patient is a partner. So the 5 A's that the Canadian Obesity Network has been promoting are absolutely applicable to any chronic diseases, and in particular to obesity management. So give the patient some homework to do in between appointments to keep them engaged, such as literature to read, give them some tools to help them to start the process. And of course, in this day and age with the internet being available, a number of the fitness apps or even the food diary apps can help them to get them engaged and keep them motivated. And devices such as the different watches, Fitbits and Apple Watches and so on. So here's another polling question. Once your patient recognizes the issue of having overweight or obesity, how do you capitalize on that momentum to help him or her to take charge of the weight management journey? Be supportive of his or her progress to date. That's option A. Or to tell him or her to lose more weight before he or she returns to see you. B. Or to help him or her to establish realistic, measurable, or SMART goals. Or A and C, which is option D. So I see that most of you voted for option D, which means supportive and engaging and helping the individuals to set goals. Okay, so let's see what Dr. Gagnon has to say in his meeting with Alain.
Hi.
Hi, Dr. Gagnon.
So I'm happy to see you again. Already 1 month since we met, and now a baby. So you lost 2 pounds since our last visit. Did you change anything?
Well, I've been thinking about what you said last time we visited together, and I was eating a lot of take out at work, and when I got home late, I ate my dinner very quickly. So I've been trying to be more careful and bringing my lunch to work.
That's excellent. You are absolutely right. And do you think that you would need to lose more weight?
Yes, I think so.
And what would be a reasonable goal that you would like to achieve?
I think I need to lose 40 or 50 pounds.
Oh, that seems quite a lot. What do you think about an intermediate target? Let's say that we start by reaching 15 pounds, and if we get to this goal in the next 3 or 6 months, at this time we will reevaluate and go for further if you want to.
That sounds like a good plan.
Okay. All right. So just to recap some of the pointers on weight management. Ask the patient, what was your lowest weight in your adulthood? It's important to set realistic and achievable goals as well as timelines that are realistic. Never ever, perhaps, if they're not under a certain weight, then they won't get there. So again, setting realistic goals are important. Unconscious eating, such as eating while watching TV, doing other things and not focusing on the action of eating. Slow down and think about where the food comes from. Take the time to eat. Have a glass of water before each meal. Be mindful of the meal time. Spend it with the family, for instance. And what is a reasonable weight loss? Because as you're well aware, there often are discrepancies between patient expectations versus physician or primary care practitioner expectations. So many obese patients have weight loss goals that are way above and much more unrealistic, if you will, than what we help them to aim for. So in a study, for example, patients choose goal weights that are nearly 3 times that of the previous weight loss. So again, because they've been through multiple journeys, they have lost weight, they regained the weight. So those are actually successes, but the biggest problem has to do with the weight regain and the relapses. So a few more points. Again, just to remind you, when it comes to the first law of thermodynamics, it doesn't matter what. In order to lose a pound of fat, we really have to, or a kilogram of fat, we're talking about 3,500 calories or 7,900 calories. But we have gone beyond just looking at the energy expenditure. We have to have our patients understand the number on the scale is not the only measure of success, and the parameters differ from patient to patient. So therefore, we're talking about perhaps not so much the ideal weight, but most importantly, the best weight for that person that he or she feels more comfortable and at the best health, if possible. And again, as practitioners, we need to find something positive to engage our patient each time when we see them, focus on them and reinforce them, make sure that the issues are dealt with in some priority, and to simplify it into items 1, 2, and 3, and so on. And remember, metabolic comorbidities such as diabetes can reduce the lifespan. As example, we have Canadian data to tell us that poorly managed diabetes can shorten lifespan by anywhere between 10 to 15 years. So when patients say they don't have the time to exercise, explain that everyone has the same 24 hours in a day, and therefore it's really identifying the priorities. And typically, if I have a patient with diabetes, I tell them the only difference between you and somebody without diabetes from now on is you've got to spend 30 minutes to devote to your body every day. And that could be in the form of meditation, physical activity, and be mindful of what you've been doing for the day. So those are some of the examples that you can help your patients to engage in. So, are there any questions before we conclude? All right. Primary care practitioners can play a critical role in obesity interventions and have a huge impact on weight management. A modest weight loss of 5 to 10% body weight can significantly improve obesity-related conditions, in particular type 2 diabetes, hypertension, and dyslipidemia. When it comes to non-alcoholic fatty liver disease, we may need to have our patients lose a little bit more weight, and again, that depends on the health condition. But we are well aware of the fact that the NIH-sponsored diabetes prevention program demonstrated, in a very compelling manner, that a 4.7% weight loss is associated with a 58% relative risk reduction in the development of type 2 diabetes in susceptible individuals. So therefore, even a modest weight loss is reaping huge benefits when it comes to metabolic comorbidities. So, on this note, the take-home message really is to engage the patient to make sure that you serve more as a partner and, in some ways, a coach as a start to help your patients in a hand-in-hand approach towards the journey for weight management. Okay, so are there any questions before we move on to the next segment of our presentation? If not, I'm going to introduce Dr. Sean Wharton, who will talk about the pharmacological advances in the management of obesity. Dr. Wharton is an internist who has a number of clinics in the GTA area in Toronto, and he has vast experience in the management of overweight and obesity, and he's now able to share with us some of his own experience, as well as giving us an overview of the pharmacological management of obesity. So without any further ado, please join me in welcoming Dr. Wharton.
Thank you. Thanks. Great. Thank you very much, David. Terrific. The intro was terrific, and really talking about patients is the important aspect here. So I'm glad that everybody's here to hear about a little bit about the pharmacological aspects and a little bit about what we're doing here in Canada, what we can do to enhance some of the treatments that we all do here. I'm preaching to the converted here. Many of you work in the field. You all work in the field, so you know about lifestyle modification. You know how to do it properly, and there's always some tricks that we can do. But let's learn a little bit more about what other adjunct therapies we could possibly use. So I want to start with this, that weight gain is natural. Okay, there's likely no one here in the audience who is lighter than they were 5 years ago. Well, there's probably a couple people because it's a pretty big audience, but weight gain is a progressive aspect of our lives. If you can gain 0.5 pounds a year, that's terrific, or maybe even a pound a year. That means restraint eating happened. That means that you were active, you were moving around. But so that's progressive small amounts of weight gain. If it's 5 pounds a year, 10 pounds a year, then that's where the challenge is, and that's where we need to look at what type of therapeutic options we can possibly look at. But make no mistake, weight gain is natural. What is unnatural is weight loss. There's nothing in our physiological mechanism. God, she did not give us a mechanism to lose weight and keep it off naturally. That's not part of the design. And so whenever we're looking at somebody who got up to 450 pounds and needs to get down, we're looking at something that's a little bit of an unnatural process. The lifestyle modification aspects are somewhat natural, but even that is unnatural. It's somewhat OCD. It's somewhat intense. That's not a natural, normal thing. Medications are not natural. Surgery is not natural. Anything that we're doing to keep weight off once a horse is out of the barn is an unnatural process. We have to keep our foot on the gas, and that's why we're here to talk about how we can do those things and keep it going. Okay, so what we've looked at in our clinic, and many of you have, a number of you have seen this research before. I've presented it here. So at our clinic, we looked at over 7,000 patients over 7.5 years working with lifestyle modification. None of these patients were on medication. None of them had surgery. We looked at how well we were able to do in terms of the weight loss. We didn't just look at their beginning weight and their end weight. We looked at their pattern of weight loss. Did they lose it quickly? Did they go slowly? Did they go back up in weight? What did they actually do? So we threw all the numbers into a computer program, and the computer program came out with 7 different patterns. And these are the 7 patterns that you see here. You can see and my clinic is an academic clinic, evidence-based clinic. There are internal medicine doctors, there's dietitian assistants, there's counselors, there's kinesiologists. At an academic clinic, the best that we could do, and it's free. Access to care is pretty easy. You can come anytime you want. It's always free. the best we could do was weight stable or minimal amounts of weight loss. You can see the majority of people are the minimal weight loss, 2.4% weight loss, which is the placebo number we frequently see in many of our clinical trials. And so that's, in my opinion, that's not too bad still. These people are gaining weight. So if they could weight stabilize or come down a little bit, that's a positive thing. But it goes to show you how challenging this all is. But you can see down in that the red line there were some patients that were able to lose a significant amount of weight loss, about 21% of their weight loss. Granted, it's a small number of patients, but there are winners here. And if you look at 2.3% of a lot of people, that's a lot of people. So there's still a lot of people that can win with lifestyle modification. It's our cornerstone. We're not throwing out the baby with the bathwater. Lifestyle modification, you guys all know about it, we all talk about it intensely, is our cornerstone. Okay, but if that person up in that purple line, the weight stable line, if he was 450 pounds and he's having challenges and he's not going anywhere, can we help him? Can we help that guy? Okay, so let's take a look at why people end up gaining weight. This is a simple study looking at 4 days of consecutive eating. These were patients at the quote-unquote normal weight, men and women, and we gave them more food every single day. They were all able to eat more food every day. You guys can all eat more food than what you just did right now. There's restraint mechanisms that we all use to eat less food, but if you didn't have a reason to eat less food, you could eat as much as you wanted to because that's important because we need to fatten ourselves up for the famine. So we can all eat more. So there's no surprise a lot of times that there is an increase in weight in a society where there's readily available amounts of food. So let's take a look at why it's so hard to get the weight off, though, once the horse is out of the barn. Because the biology is that you defend your highest weight. And so if you remember this principle, it's always going to be there for you to understand that why weight loss is so challenging for your patient. Once you're at 450 pounds, you go down to 425, your brain is saying, I don't like this, I'm defending my highest weight at the 450 pound range. And that makes sense. Back 10,000 years ago, if you were 100 pounds and you went down to 60 pounds and you stayed there easily, that'd be a bit of a challenge. You wouldn't be able to catch the next water buffalo all that easily. And where does this happen? It happens in the hypothalamus. We know there's inflammatory tissue, there's inflammatory reactions happening here, and scar tissue that actually happens. So there's a stamp that says 450 pounds, and it happens in the brain, and that's why the brain is the main component that ends up looking at this. We don't get this type of scar tissue if it's short-term weight gain. Pregnancy or Matt Damon gaining weight for a movie role doesn't necessarily add to the scar tissue. But if you gain the weight over a 5-year time frame, a 10-year time frame, and you got to that 450 pounds, the chances of you getting down easily is going to be challenging because there's a serious inflammatory scar tissue stamp there. Okay, so what are the hormones that are working? And you guys have seen this slide over and over again. Ghrelin is kind of the bad guy. It was the good guy back in the day, 10,000 years ago, but the bad guy now makes you hungry. And then all these other hormones are the ones that help you to stay full. So as you lose weight, you get an increase in the bad guy, the ghrelin, and a decrease in the good guys. How can we adjust that? How can we deal with that? The important thing here is that we know that these changes in the increase of the bad guy hormones and the good and decrease in the good hormones doesn't go away. So those patients of mine who were 21% weight down and they've been keeping it off for a good amount of time, they're doing excellent work, they're still hungry. They have a desire to eat, their GLP-1, their CCK are low, and their ghrelin's high. So they're still jonesing for more food at year 1, at year 2, at year 3. If you're able to keep weight off with lifestyle modification, you're always doing something intense to try to react to the natural response of the brain to get the weight back up. And that's what this study showed, and it was the first time that we'd had a mechanistic and physiological study to show that these hormones don't change regardless of how long you've been able to keep your weight off. Okay. And this is in Ireland, a picture of the famine. So we know that as soon as these guys were losing weight and taking in less calories, their only ability to survive and to stay around was to have more hunger, have more cravings. If when you were bigger, you didn't like certain foods, when you're losing weight, you're going to like foods that you didn't like previously. Cravings have to go up because that's a survival mechanism. Hunger has to go up. You're going to eat and find things as much as you can. And that's the system that we're actually working in. So we know this, and you guys have seen this before as well. The Biggest Loser studies become very popular. Kevin Hall is from Ottawa, actually. He's a Canadian. And he looked at this. So this guy here lost a lot of weight, about 140 pounds. And then he regained the weight. Most people in The Biggest Loser regained their weight. The thing is when he regained his weight, his metabolic rate was 500 calories than it was when he was previously at that weight. So he's burning 500 calories less. He's working out, he's trying to eat less food, yet he has this major challenge of having a maladaptive metabolic system. So the question of whether seesawing in your weight is going to be a challenge, yes, it can potentially be a real challenge if you keep on driving your metabolic rate lower and lower. So we know that the around the placebo amount of weight loss that we end up seeing is about a 3% average weight loss over the long term. Anyone can lose weight with lifestyle modification for a 6-month time frame. Question is, can you keep it off for 4 to 5 years? If we look at 4 to 5 years, you're still in a program, you're still working hard. Most people regain, but about a 3% weight loss is there. So that's the placebo number that we usually see in most clinical trials. So what we need to know is that, as I said, lifestyle modification is our foundation. Some people can get down, some people can stabilize, you can get small amounts of weight off. And if we want to get more weight off, we would add pharmacotherapy or surgery. So if it doesn't do more than lifestyle, we don't want it. If it doesn't give me greater than 3%, if it doesn't extend longer than 3 months or a year, I don't want that medication. It's not adding anything to the natural process of lifestyle modification. Okay, so if we look at, are we going to, and that's why placebo-controlled trials are such an important aspect, because if it doesn't do more than placebo, quote unquote, all the hard work of lifestyle changes, we don't want it. So every trial that we look at has to be placebo controlled. So what medication surgery have to do? One, they have to increase the number of patients that are responding to lifestyle. If we have 10 out of 100 patients responding to lifestyle, with the medication or surgery, it better be 20, 30, 50 patients out of the 100. It needs to increase the magnitude of the response that we're seeing. The magnitude, 3% weight loss is what we get with lifestyle. This had better be 5, 10, 20, 30% weight loss. It needs to increase the duration. If we all know that everyone can keep weight off about 3 months, 6 months, this better extend it to a year, 2 years, 10 years. Okay, so how can we do that? With pharmacotherapy or with surgery. Let's talk about pharmacotherapy, a topic of this talk. We've tried it multiple times in the 60s and the 70s and the 80s, and we failed horribly because there was lots of side effect profiles from the medications. Granted, back at that stage, we didn't really understand the neurobiological processes that were going on in the hypothalamus. I believe we now know more and we can use better medications, but at this time, things were a little shoddy, and certainly it was a major problem, and many of these medications are now off of the market because they cause major issues. Therefore, there was a real gap in the time frame of new pharmacotherapy agents coming to market because of this fear that you're just going to fail again, you're going to cause side effect profiles, it's going to be a problem. But with our greater understanding of physiology and neurobiology, we have safer and better medications. We can't give up. We didn't give up in cancer treatment when certain medications were causing toxicities, HIV treatment. We kept on moving forward. And with the pharmacological agents in obesity, we need to do the exact same. But what we don't need to do is to continue to have non-evidence-based medications that are causing problems and not giving us any benefit. And we know that many of the over-the-counter medications that we currently have can cause problems. For instance, green tea extract, we have seen, can cause fatal liver damage, as in death. And is it going to give us a benefit? Well, if it's not giving us a benefit, then it's not worth this one person out of 10,000 dying, certainly. So let's, instead of telling you more about over-the-counter medications, we're going to play a little video for you to show you what has happened in this field.
Supplements like green tea extract. We're learning it can have dangerous, even weight management, and Health Canada is saying they are safe and effective. Should they be doing that?
As a natural product, they have different rules than they would for a prescription product. And they don't have to be as stringent in terms of having a big clinical trial where there are thousands of patients, half of them on placebo, half of them on the medication. And then we're actually able to see which one decreases weight and keeps that weight off longer. To me, that's a real clinical trial.
They're not being judged to the same standard that pharmaceuticals are.
Exactly. And they actually should be.
The product that you and the doctors connect to your mother's death doesn't actually work for losing weight.
I don't even know how to vocalize how that makes me feel. I feel a little stunned by that. Green tea extract is proving more and more to hurt people, kill people, and that it also has no proven benefits to help.
Okay, so that was just a little snippet from a marketplace episode that I did. And there was a little bit that glitched on the video where they would have shown me a little bit talking about the fact that these over-the-counter medications don't work, and that the claims are false, that they decrease weight. Most people just look at the fact that it says that it's going to work for weight. They just grab it off of the counter. They don't read the actual fine print. And then, and I stated that they don't work ever. So what they did was they actually went to the Natural Products Board to find out, where did you get this label from that says that it decreases weight? There were 4 studies that they had looked at. One of the studies had 10 men in the study with no placebo controlled arm, and as a result of these very shoddy studies, and evidence-based medicine doc at Mac took a look at them and said, there's no evidence here that we can actually, I don't know if it works, I don't know if it doesn't work, because these trials are actually nothing. They're not helping me in any way to make a decision. So that is where some of these labels end up coming from, which is a challenge. But so let's talk a little bit about medications that actually do work and the actual prescription medications we have here in Canada. So Orlistat was approved in 1999, and liraglutide 3.0 was approved in 2015. So as of right now, we have 2 medications that are proven to decrease weight here in Canada. In the States, they have 6. So we have 2, they have 6. The majority of the medications in the States that have come onto the market recently, 4 of them have come onto the market in the past 3 years. They all work in the hypothalamus. Again, the biological process of working in the brain is what we actually really need. Let's talk about the medications that we do have here. So Orlistat, as everybody knows, decreases the absorption of fat, and at the bottom of that slide you see there's a 30% decrease in dietary fat. It goes out to the other end. Now this is bad fat and good fat. There's not a discrimination between the good omega-3s or the salmon oil fat. It is just all fat. You know that this side effect profile causes a little bit of a challenge, but it does decrease weight. In the clinical trials, we see that there's about a 10% decrease in weight. When we look at meta-analysis of other smaller trials, we see that the actual weight loss is about a 3% weight loss on top of the placebo weight loss. So when you think of Orlistat, think about a 3% weight loss if the patient can stay on the medication. Side effect profiles include fatty stools and frequency and urgency. And so that is one of the challenges that keeps people from taking the medication over the longer term. But if you can tolerate this medication, if constipation is one of your issues and this helps out, this is not a bad medication to actually use. There's rare liver damage, so I would watch your patient's liver enzymes. I had a patient that developed liver failure, ended up in the hospital, taken off the medication. The liver failure ended up getting better. The jaundice got better. The LFTs got better. So I got my firsthand experience of it. So I watch for all of my patients. Whenever you get burned once, you're always going to make sure to watch for it. But most patients will not end up getting that. But I monitor liver enzymes. So what I think we need, because this is a deterrent type of medication, it just deters you from eating extra fat. If extra fat is not your issue, if it's carbohydrates, then this is not going to work all that well. We need smarter medications that work up in the brain that control things like portion control, cravings, those type of things that drive other aspects of gaining weight. So right now we know that liraglutide 3.0 is the only medication that we have out there. What are the clinical trials that got this medication to market? They're called the SCALE trials, and here are the four SCALE trials. The medication is in the blue line, and the placebo is in the gray. You can see the placebo is always around that 2%, the 1% range. So that's the average that we get with lifestyle modification. But we can see that we can get about an 8% decrease in weight when you add on the medication. So here is one of my favorite SCALE trials. It's called the SCALE maintenance trial. So what we did in this trial, I was one of the PIs for this trial, is we looked at patients who could lose weight with lifestyle modification. You know, go to the gym, work out, eat a little bit better. Let's talk about some counseling. Let's talk about some behavioral therapies. What are you eating? How are you eating it? Let's change it. They lost their weight. They're at that time frame now where 6% of their weight is down. They're at that 3-month mark, maybe the 4 or 5-month mark. This is where they start to tank. Their motivation starts to go down. Their GLP-1 goes down. Their ghrelin is up. This is where the weight regain happens. Here we introduce the medication. You can see with the introduction of the medication, the weight stays off even further, and the placebo arm is relatively stable. And so there was an extra amount of weight loss that happened here. So I would expect this, right? This is what I want to see in the trial. If you're going to bring a drug to market, it has to do more than the placebo arm, and it has here in this clinical trial. That's why it's here. So let's take a look at in my practice, we took a snapshot of 100 patients on this medication. What we looked at is how well are you doing with the weight loss on the medication. We can see here that there's a variability. If you look at the right side of the graph, there's patients who lost a lot of weight, 15% of their weight, about 15 kilos. So they're doing really well. The cluster of the patients is on the right side. But as we move to the left, we see that some patients on the full dose of the medication are not losing much weight at all, and some are actually gaining weight. So, and this is what we saw in the clinical trial also, that there was a good group of patients who responded very nicely. They loved it, they're on it, they're doing well, but there was also a percentage of patients who didn't do so well, and some that actually ended up gaining weight. So who are these guys? Who are the guys doing really well? I'd like to know who they are, and maybe I can find patients like this and tell them, you're going to do well on this medication. Who are the guys doing really poorly? I'd like to know who those guys are too. Maybe the guys doing poorly, they don't have a portion control problem. Liraglutide does a great job of controlling portions. It helps a bit with cravings. Many of my patients have actually said that. Maybe there's a food addiction issue here. Maybe there's an emotional issue here. Maybe there's more of a ghrelin issue. Maybe we need a ghrelin blocker for these patients, a PYY increase for these patients. Maybe they're not the GLP-1 guys. So what are some of the side effects we saw with this? Number one side effect is nausea. So we would expect that. About 44% of patients got some degree of nausea, but only 4% of patients ended up discontinuing the drug due to nausea, i.e. 40% ended up getting much better after you keep them on it. So the nausea goes away after time. So it's nice that there's not a whole lot of side effect profile here. You can get some gallbladder issues, and acute pancreatitis are rare, but the major issue is this nausea that goes away. So let's talk about some other medications. So medications that may be coming to Canada. We won't talk about all the medications in the States. We'll primarily talk about ones that may be coming here. So this is an interesting compound, and what they've been doing recently is combining medications that have a synergistic effect. They can work at 2 different spots and then end up giving an enhancement of the way the medication works. So naltrexone is as a medication we have here in Canada already. It is an addiction medication. We use it for addiction to either alcohol or to opioids. And bupropion is a medication we have here as well, kind of an addiction medication as well. We use it for the cessation of smoking, again, another addictive type of behavior. It's also an antidepressant. So combining these 2 medications allowed us to use smaller doses of the medications, decrease the side effect profile, and have a synergistic aspect to it. So you can see here what the bupropion does. It goes and it activates the POMC. POMC allows the activation of the MC4. MC4 is a receptor in the brain that helps to decrease weight. Now, what happens with the bupropion is that the activity ends up decreasing because these extra enzymes come and start to destroy the activity of it. But with the naltrexone stops those extra enzymes, allows the bupropion to have more of an activity, activate the MC4 receptor in a greater fashion, weight loss being greater. So the clinical trials should look like this, right? If we're talking about this drug coming to market, the medication, again, should have a greater effect than the placebo. Placebo's here. Here's the medication with a decrease in weight. The first graph has the two medications, the lower dose of the medication, the lighter blue, and then the higher dose of the medication. And the second clinical trial that was done, CORE2, had mainly the higher dose of the medication. So we're seeing about an 8% decrease in weight for those who finished the actual trial. Many people dropped out of the trials. They drop out of all weight management trials. About 40% of people drop out of weight management trials. That's the way it goes. It always goes that way in all trials. If you look at the people who dropped out, it's about a 6.4% intention to treat analysis. But if you look at the people who finished the actual trial, it's about 8%. So that's a positive thing. Side effect profile. The main side effect, again, is nausea and headaches. Again, these things that work in the brain tend to give us a little bit of that nausea, headache, dizziness type of stuff. So there is you can see a greater amount. This is the placebo here, and then the two different doses, we can see the amount but the number of people that stopped the medication as a result of this, you can see that there's not there is a significant difference here in terms of the number of patients who ended up stopping it as a result. But if we look at each of the different categories, it's not a huge amount. The interesting thing is that patients tend to tolerate side effect profiles if they're getting the effect of the medication, and they try to push through and try to see whether that side effect will end up going away. They sometimes even stop the medication and go back to it and see whether that will end up being better. With liraglutide, that's been the experience because that's what we've been working with. So patients push through and push through if the positive effect is actually happening, which is fascinating. So lorcaserin may be another medication that may end up coming to the market. We're not sure as yet. This is a little trickier. And this is a 5-HT2C receptor agonist. This is the cousin of fenfluramine. Fenfluramine is a non-selective 5-HT2 agonist, and it affected C and B. B is on the valves of the heart. So if you're affecting the heart valves, you're going to get heart problems. So fenfluramine was taken off the market in 1997. It was part of the fen-phen problem. It was the bad guy in the fen-phen. The phentermine was the good guy, and everything was okay there. So they decided to make a medication that would decrease appetite, decrease weight, with just the 2C. 2C is in the brain, and this medication worked relatively well. The challenge is that we didn't see a significant amount of weight loss with this medication, so whether it's going to come to market is a question because the weight loss effect is not as big as we would actually like it to be. Main side effect, again, headaches, dizziness, brain stuff. So this is a paper that we published looking at all the different medications and putting them on a graph looking at placebo subtracted weight loss. So again, placebo is about a 3%. So add 3% onto this and you'll get about a 6% weight loss for orlistat. And you can see there that naltrexone at about a 4.2, add 3%, you get about a 7, and here 7.2, and you get here about 8% weight loss with lira. Okay, so now how much of the anti-obesity medications have been prescribed in the States? This is data from the States. So these are the people, let's look at the diabetes arm. These are the people who've been diagnosed with diabetes in the States. About 10% of people in the States have type 2 diabetes. The number of people treated for type 2 diabetes is pretty close to the number of people that actually have it. That's pretty good. The number of people with obesity is about 45% in the States. The number of people treated with pharmacological intervention is about 1%, 2%, tiny. That's a problem. So access to care, access to medication is the major issue here, and also knowledge, patients knowing about it. So that's a challenge. So which medications are being used? Of that small percent of medications are being used, it's phentermine. That's the number one medication. Phentermine is in the yellow there, so it is being used the most. And the other anti-obesity medications are there in red. So you can see the newer agents that have less side effect profile. Challenging, sorry. Less side effect profile are not being used quite as much. But you can see that the introduction of a diabetes medication, the Sglt2 inhibitors, that is the blue arm. Look at the rapid rise in the use of the Sglt2 inhibitors. So this is likely due to a number of things: the recognition of diabetes as a medical condition, the fact that it's covered on most of the drug plans and government drug plans. So this is an unfair advantage here, and we really like to see obesity medications getting covered and getting the recognition that they need. So in the end here, what we do know is that with all of our treatment options, weight comes back. So if the weight comes back, let's try to use as many things as we possibly can to mitigate that, to stretch that out a little longer, to decrease that eventual weight regain as much as we possibly can. So in conclusion, lifestyle management, don't give up. It's the cornerstone. It's what we need. So Contrave is not going to work without lifestyle modification. Saxenda is not going to work without everybody working with the lifestyle modification also. So we need to know that that's our cornerstone, that's our baby, and we're not tossing it out. But what we are doing is for those people that need extra help and potentially have extra cravings, and that's maybe where things like Contrave could come in. Maybe it works with addiction, because we know that there's 2 addiction components there. Maybe that's somewhere that it can end up working. That person may get some adjunctive treatment, adjunctive help. So medications are promising, they're effective. And in conclusion, weight gain is natural. Weight loss is unnatural. Hormone regulators adjust to force weight regain, prevent further weight loss. Interventions have to be targeted to these hormones, I believe. Bariatric surgery and pharmacotherapy can enhance lifestyle modification. Thank you very much for your time. We'll stick around, eh?
So now we have a few minutes for questions, so please feel free to come forward with questions. And there are microphones that will circulate.
I'm Sean.
I have a quick question. In your practice, in your clinic, do you use the phentermine or phentermine with Topamax? If so, when?
Okay, so I can answer that briefly. Phentermine, I don't use. I do know some doctors in Canada that are using it. It's not off of the market here in Canada. It's just hard to really get. Because my clinic is 6 clinics, 26 doctors working in the clinic, the cohesiveness and I want everyone to do the same thing at the same time, so we're not one-off. So I don't do any off-label use of medications, topiramate, naltrexone, but I send my patients who I believe may benefit from this to a few physicians who do use off-label medications, and I don't see this as a problem. It's coming, it's going to be here. There's no reason why somebody who's having a real challenge can't try something different. So we just can't do it in our clinical practice, but I do have some very good physicians and colleagues who can stand by the use of off-label medication. Aspirin is off-label for heart disease. Right? I mean, so off-label is not the worst thing in the world as long as you're doing it properly with appropriate backup.
Well, the other important point is the phentermine is not available at the dosage that were used in combination. So the same thing is true for Topamax or topiramate. So I think it should be emphasized that that's the reason why there's combination therapies available to minimize the side effects and to maximize the effect on body weight. Yes?
Thank you for an interesting talk. Do you ever initiate medication use even in kids who are not successful, or not kids, you don't do kids, I do kids, but in individuals who are not attaining their objectives in terms of lifestyle modification?
Who wants to take that one first? Yes, I do. So if they're not behaving properly, quote unquote, that is a judgment call, that's a bias. And if Michael Vallis is here, he'll be able to back me up on a lot of this, in the sense that we can't make that judgment call for the patient. They may have significant issues in their life that they can't actually do the lifestyle and the behavioral changes, emotional issues. We can't deny them the medication. So I tell every patient who walks in my clinic that the medications are available. You can start it now, you can start it later. We're going to always work with you in terms of lifestyle modification. Whenever you're ready for that behavioral change and you've got there, that's perfectly fine. But we will give them the medication regardless. Someone who has hypertension, who's not going to do the DASH diet, we give them antihypertensives. And on and on and on. We do it all the time. Lifestyle modification is really hard, and not everyone can actually do it. So in my opinion, it's right to offer the medications to everybody.
Well, again, I also like to echo what Dr. Warren said, but it's also important to emphasize that obesity is a chronic disease, so we require a long-term solution. And as you've heard, it's really not the patient's fault that the health behavior changes are unable to help them to lose a significant amount of body weight or sustain the body weight. And that's where pharmacotherapy is exceedingly helpful. And even though we have to be realistic in terms of the weight loss, it's not going to be 20 or 30%. But nonetheless, when we're talking about improving health and improving the comorbidities, even a few extra points, a percentage, in addition to the health behavior changes, are very significant.
When you're discussing medications with your patients, what do you counsel them about the duration that they're going to be on the medications for, and what happens if they go off of them?
Okay. So duration of medication, that's always the number one question that patients have. They have a little bit of questions about the side effects and that, but they're like, Doc, do I have to stay on this forever? How long do I have to stay on this? That's our number one real question, because they don't want to stay on medications over the long term. So everybody here, if you're going to be starting medications, you have to be prepared for this question and know how to answer it. So what I state is that pharmacotherapy should be part of your weight management strategy. What does that mean? It means to a large degree, and I explain it to the patients, should be part of your weight management strategy. Every day you have to have a weight management strategy. If during the summer your weight management strategy is to go to your parents' island in Greece and just walk around all day and do the hills and just eat cucumbers and tomatoes, that's your weight management strategy for the summer. You may not need the medication during that stage. If you're running a half marathon every February, March, you may not need the medications then, but you may need them during Easter. You may need them during Christmas time for that entire month where things are challenging. You may need them during a depressive instance. And how long are you going to stay on it? Let's see the people who are responding to it. They're doing a great job. I believe people can cycle on and off of the medication. I believe new medications are going to eventually come. You may stop one medication, go on to another, go on to both, do combo. This is a fluid field, and so they should not be afraid of the duration, and they should not be afraid of rebound. I tell people that what happens if they stop the medication, they go back to being them. They don't rebound another 50, 100 pounds. They just go back to being wherever they were. If they were on the weight gain strategy, they're going to start regaining weight. If they were doing really, really well, they may end up doing really well when they come off it. I don't know. They go back to being themselves, and that's an okay thing.
But perhaps there's another point that we should underscore, and that is in individuals who are on anti-obesity medications, and they often say, Doc, I'm not losing weight. Well, I think it's important to understand that if they are at the weight maintenance phase, what the anti-obesity medications do is really to keep the weight off. So typically, if they stop the medication, that's where the weight regain starts to occur. So many a times you really have to educate not just the patients, but also the primary care practitioners to understand that if you don't see weight loss, it's not a failure. It in fact is the drug is working. And the other common question is, Most of the time, anti-obesity medications are approved in terms of clinical trials that have been conducted for 1 or more years, and that's the requirement stipulated by the FDA. And that is not necessarily the endpoint, that if you have a patient on the drug for 1 year, that you stop after that. As long as they're not experiencing any side effects and as long as they're benefiting from the medication, you can certainly continue. Again, emphasizing that obesity is a chronic disease, it requires a long-term solution.
I have a question around orlistat. Do you see in the patients that are on orlistat any changes in inflammation biomarkers? So do you track any of that in the blood tests? Do you see an increase in inflammation, given that they're stripping all the oils out?
Then that there may be an increase in inflammation markers because they've lost some of the good oils, the omega-3s that help with the inflammatory markers. We haven't specifically looked at that. We do know that in the clinical trials, in the Zendos trial, diabetes ended up decreasing, but whether HSCRP or ESR or TNF-alpha, IL-6, whether those have had significant changes, I don't know. The challenge is there's not very many people on the medication to actually do to do that type of research with, but I haven't seen anything like that.
But certainly in patients who are on orlistat, you see a reduction in the triglycerides, primarily because of the improvement in postprandial dyslipidemia. So there are certain benefits. When it comes to inflammatory markers, there have not been any long-term studies done specifically to look at, for instance, CRP or TNF-alpha or for that matter, interleukin 6 or 12 and so on.
Yeah, we do know that they may need some supplemental vitamins, the fat-soluble vitamins, the ADEC vitamins. So they may need some A, they may need some vitamin D. And if they're on warfarin, they may need vitamin K. So if you're getting rid of fat, and you may need those fat-soluble vitamins.
Okay. There's one more quick question.
Oh, I think it's right here. Yeah.
Yes. My question is about the persistence of the effect on appetite and hunger hormones after the run-in period. So you had shown a slide of a very low-calorie diet with the persistence of the effect of hunger and appetite a year later, and then there was a separate slide for the scale trial and the use of Saxenda continuing the weight loss. But I just wondered if they're still on the Saxenda or if they come off, is there still that persistence of effect within those hunger hormones?
Excellent. That's a really good question, and I'm sure that they would like to look at that. Like somebody may end up looking at that. Stop the medication. Does GLP-1 go back down to the original level? We certainly see weight regain starts to happen after the medication stops, and so we know that that's there, and we also know that if you're on medication, you're going to eventually start to regain weight, even on the full dose of the medication. So go out to year 3, being on the medication, we start to see an increase in the weight coming back. Granted, that increase is nice and slow. There's still a nice difference between the placebo arm and the medication arm at the 3-year time frame, but the weight's coming back up. So why is the weight coming back up? Is the GLP-1 not working as well, or are other components overriding that? Is ghrelin getting more intense? Is PYY so low that it's causing a problem? So those are some things that we eventually have to look at in this new field.
Okay. Well, on this note, I'd like to thank all the speakers, Dr. Wharton, Dr. Gagnon, and the sponsor for this meeting, Valiant Pharmaceuticals, for sponsoring this meeting, and thank you all for coming. So please join me in thanking Dr. Wharton and Dr. Gagnon.
Thank you. Excellent.
Congratulations.
Oh, well done.
Thank you.
Well done. We're finished. Great job. Thank you. That was my first time seeing the actual videos. Cheers. Was it okay? Oh, good. Thanks. Finally finished up. Here you go.
You can have this, and you can have this. So it worked out to put those slides back in, eh? They were. Those slides were nice talking points.
So you're saying the gain was automatically going up on this here, eh?
Number 2.
Yeah.
Yeah. Somewhere in the gain structure. I'm assuming it's. I want to check how high the gain is on this because it's so much louder than the other one. Just as is. Sensitivity.
Oh no, no.
Yeah.